increments. And then, so if a country the size of Cyprus could do it, why couldn't a state do it? And some people are concerned, like, can the smaller states like Vermont or New Hampshire do it alone? Do you need to do a regional plan? And some of these questions will, there are too many questions to fit in one evening. So we'll try to make the best use we can of the time that we have with our guests here today. And so I'll introduce Mike Fisher. Really excited to have him here. He's a former Vermont state representative. He served from 2000 to 2015. So some of you may recall that that's when Vermont was trying to get healthcare for everybody. Had done a Catamount Health, which is kind of like the federal exchange, only state-based. And we're working towards trying to figure out how they could do more like a single payer. And one reason people are very excited to have this program is because across the country, activists are fighting against the story that, oh, Vermont tried it and they failed. Well, Vermont didn't actually implement it, so it couldn't fail. It never got tried yet. And then it wasn't actually a single payer system. To be a single payer, it means one payer, and as long as you're not able to roll in Medicare and Medicaid and all, then you can't have a single payer. So just want to give people more information so it's easier for them to have those discussions across the country when people are saying, yeah, that's not possible by states because Vermont failed. So very happy to have these folks with us. We had a lot of questions about what states can do in the absence of a universal healthcare system. And if we get to those questions, it may be that they may not have the answers for those, but I think that they'll have some light to shed for us. And so back to my introduction for Mike, very happy to have him here today. And before serving on the state legislature, and while he was serving there, he served as a social worker for Addison County Mental Health. And since leaving the legislature, he has been working as the chief healthcare advocate for Vermont Legal Aid. So thank you so much for being here tonight. And Robin Lunge was the director of healthcare reform under Governor Shumlin when he was trying to work our way through figuring out how we could get the most people covered, get the best care, best access and affordability that we could. And when Act 48 was passed, she was placed on the Green Mountain Care Board and has been there ever since. So she has a wealth of experience. Very happy to have her here as well. So thank you both. And then Maria, I'm really excited that she's able to be with us here. We have a summer internship program. When I say we, it's not one payer states, but actually Physicians for National Health program. We have an internship for typically medical students, but Maria was an outstanding undergraduate we were excited to bring on board. And she is actually taking a gap year and doing more activism while she's applying to medical school. So she's hoping to enter medical school next year, but she has some extra time right now to be putting to use what she learned this summer. And she is a second-generation Cypriot refugee who graduated from the University of Arizona with a degree in physiology and medical sciences and a minor in mathematics. And really looking forward to seeing what she does in this year, using what she has learned this past summer and the skills she's gaining from opportunities like this to moderate and have more public speaking experience. So thank you much. So Maria, would you like to take it from here?
Yeah, thank you so much, Dr. Keller. So I'll just do like a quick little recap on Cyprus and their system and how that works, and then I'll turn it over with a couple questions for Mike and Robin. But basically, Cyprus went from being the only EU country to not have some sort of national healthcare system to a system that's really applauded by other countries. So I was really inspired by it. Their life expectancy, just to put things into perspective, is 82.3 years old, which is above the EU average of 80.6. And then their infant mortality rate is 8.36 per 1,000 live births. Before they started with YISI, their healthcare costs were around 5 to 6% of GDP. YISI is the new national healthcare system that they implemented. And then how it was before was that the job would pay for health insurance, and then there was also private insurance available, and a lot of Cypriots enrolled in private as well as whatever their job was covering. As for the infrastructure currently, they have 4 doctors per 1,000 population, which is slightly above the EU average, and then above the US average of 2.6 doctors per 1,000. And then their nurses per 1,000 population is only 6, which is lower than the EU and lower than the US, which is 9.22. So it's a very small country. For medical education, they're recently in the works for the legal framework to have a university hospital. Currently, they don't. So medical students are deployed to state hospitals, but that limits their training in terms of research and academia. So it seemed kind of sudden on why Cyprus rolled out this national healthcare system. A lot of the citizens didn't really get a lot of warning. They were just like, oh, here's a pamphlet. It's going into effect. And so it's actually been in the works since 2001. And following a 2013 bailout, Cyprus was in agreement with their lenders that a national healthcare system was part of structural reforms that they needed to implement. So in 2015, a study by WHO determined that a single payer system was the only one feasible for Cyprus. And then the rollout of YESI, which is that national healthcare system, ended up being seen as the only positive of an otherwise mediocre presidency. It was originally legislation completed in 2017 and started rolling out in 2019. So it led to really positive views for that presidency. And then because they also were rolling out YESI during COVID, which I'll go into, so there were private insurers still operate there, but they're really limited. And mainly it's for people who travel abroad in the EU. So it'll be covered for like students or just if you travel a lot. That's not the rule though. It's just general rule of thumb. They rolled it out in 2 stages. So first off, they did what we would call primary care, which is different than what the US primary care definition is. And their term primary care would be like your general practitioner or your family doctor, which they call a GP. And then that would include also any x-rays, blood work, or ultrasounds. So they rolled that out in June 2019. And then secondary care, which would be specialists and preventative care. And then tertiary care, which would be hospital visits and elective surgeries, all were set to roll out in June 2020. So it was supposed to only take a year. But because of COVID, they delayed the secondary care, but wanted to roll out the tertiary care per usual because of all the hospitalizations and everything. So altogether, YESI covers a variety of services such as palliative care, rehab specialties, your general practitioner visits, emergency care, pharmacies, medical devices, etc. It's a huge list, but it covers a lot of things. And then it's also financed by general income and taxes on different sectors of society, such as those who are on pension, those who own their own business, etc. It's a global budget, and so the total money depends mainly on employment. So the global budget is in terms of the amount of money that stays in the system will be where it's budgeted and where it goes to will change and fluctuate, but the overall money will stay the same generally. So it's 4.5% of one's salary is paid by the employee, taken out from the employer, and then also by the government. And so if more doctors enter the system, they take some of the salary of the other doctors because the overall money in the system will stay the same. And then there's also a separate budget for different specialties. So primary care, pediatricians, each specialty has their own, and then hospitals and pharmacies all have their own salary. So if a medication comes onto the market and there are other cheaper medications, they'll go down a little bit in price so that it compensates for that more expensive medication. As for who's covered, it covers Cypriot citizens and their dependents, EU citizens and their dependents, non-EU citizens with permanent residence or working status, those with refugee or protected status, and then there are also special cases granted by exceptions by the federal insurer. They also have, for the army and students, they don't have to buy into it, so they are also covered for free. Doctors and hospitals are paid on a unit system based on their specialty. So patients have the right to choose and change their doctors, but you do need to be registered with a general practitioner of some sort. And doctors are either public or private. So you can't double dip and be in the YESI system, but also seeing patients privately. GPs are paid per head that's registered under them, so on capitation. And then each visit, service, etc. for the specialties has its own unit. So at the end of the year, the overall amount of money or in that specialty or that budget is divided with the accumulation of all the units. So specialties originally started at 15 euros per unit. Now they're around down to 9 euros per unit because more doctors are enrolling in the system. Copays are also really cheap there. It's generally between 1 to 10 euros. You'll pay up to 25 euros for non-referral outpatient visits, but they do max the copays that you pay each year. So it's between 75 to 150 euros per year, depending on what your income level is. So just to sum up, originally no one thought it would work. It was very little information made public on how it was going to work, and the pamphlets that they handed out were really confusing. But where we're at right now is that 82% of people in Cyprus are happy with the ESC services. 80% stated an improved quality of life, and then there was a 99% renewal rate by the doctors in 2022, and the only 3 doctors left were because they moved out of country. So it wasn't any issues with the system. So that's just a little recap on Cyprus. If Mike and Robin are ready, I do have a question sort of to turn it over to them.
Is your question, how do we join the European Union?
I wish. Yeah. So mine is actually pertaining to the ACA. So I know Dr. Keller mentioned it a little bit, but it seemed like, from my understanding, Vermont had a lot of protections for their Vermonters already before the ACA. So the only new protection really was that young adults could stay on the parents' health insurance until 26. And it seems like, in my opinion, ACA made it a little bit harder for Vermont to pursue a universal healthcare system. So can you talk a little bit on what they did before that, before ACA went in, and then how ACA impacted Vermont?
You want to start, Mike, or shall I?
Well, I think I'll start with a few. It's true, Vermont had done quite a bit in the years preceding in terms of improving access. VHAP, Vermont Health Access Plan, was that 150, 185 FPL? I'm sorry if I'm going to speak in acronyms, I shouldn't. It had a higher eligibility level. And of course, we had passed Catamount. So it's true that there's aspects of the ACA that didn't feel like a step forward. But there were other aspects, the premium tax credits certainly was a new dynamic for people who were above Medicaid levels or above those income levels. And lots of intricacies that I'm not going to go into in any kind of detail, but I'll just mention, requiring all nonprofit hospitals to have free care policies. That was an ACA dynamic. And then the one, for the insurance junkie, or the healthcare policy junkie, we talked about having community rating pre-ACA, but the definition of the community was really different than the definition of the community, at least in the exchange, because now the community is more the marketplace, so it bridges insurance companies. So that, I don't mean to be defensive in any way that the ACA replaced the need for real, significantly deeper reform. But it's hard for me to not mention that there were some other aspects of it that I think has improved people's access to care. Robin, what am I missing?
I think you hit the major ones. I do think that the premium tax credit structure, in terms of particularly now with the new subsidies, smoothed out the prior Catamount subsidy structure in a way that was more fair and more intuitive for people. I think from a pure legal perspective, I am a lawyer by training, although obviously I don't practice now. I think where the ACA made things harder for reform was in federalizing insurance regulations. So that did, to some extent, limit states' authority to do things on their own. However, in our state, the vast majority of the commercially insured market is self-insured. And so the ACA, quite frankly, is less of a barrier than the federal ERISA law, which preempts state action for any self-insured business offering plans. So that's by far the bigger, I would say, commercial federal barrier to moving forward with something like anything close to resembling a single payer system.
And then we can't forget, did anyone notice we had a difficult launch of the Vermont Exchange, of Green Mountain Care, of the Vermont Exchange? That, I think, it's not a legal barrier, but it became a political barrier, honestly. You know, the dynamics when we were trying to launch our, you know, I'll say largely publicly financed. I don't think I tend to use the term single payer, because Betty, you're right, it wasn't. The political dynamics were, as anybody, I'm sure many here remember, were incredibly difficult, because we had such a challenging time making that system work. And the perception out there was less confident in the state in being able to pull it off.
Yeah, absolutely.
And then do you also mind elaborating a little bit about Act 48 and then what Vermont has done since the ACA, just expanding on that? And then either like actions of either executive or legislative branches to try and improve healthcare access and affordability since ACA has been passed.
Sure. Do you want me to take I can do a quick Act 48 overview. Act 48 established the parameters for a state-based universal coverage program, trying to get as close as possible to reducing administrative burden and as close as possible to what people think of as a single payer. I think to Betty's point, it's quite challenging for a state, given our current federal landscape, to truly get to one payer, or quite frankly, to achieve the kind of administrative savings that other countries have achieved, because the federal payers are not going to let go of claims, even if that's not what's being used to pay, because that's how they know what's happening in terms of what care is being provided. In Act 48, it established the basic parameters of a program. It also established a series of studies to develop the details, including the financing plan. And as well as Act 48 also established Vermont Health Connect, which was the state's insurance exchange. So there were really those two big components to it. In terms of the universal coverage program and the financing plan, there was a lot of work that the state did to develop a financing plan. The financing plan was released in 2014. And ultimately, I think the numbers didn't work for a lot of folks, in terms of, it felt like the financing plan included a payroll tax as well as an income tax, sort of a split. So the payroll tax in order to maintain the employer coverage and also to maintain the federal tax deductibility that is favorable for employers. And the income tax was meant to kind of mirror the ACA premium tax credit structure, in order to basically try to keep at least in the initial years, the payments coming in roughly equivalent to what had been happening prior. One of the big challenges in Vermont with that particular, or quite frankly, any sort of payroll tax scheme, is that we are a state of small business. And so when you're a state of small business, you have a lot of winners and losers when it comes to how much businesses are paying towards health insurance. And so particularly in the small business community, you have some folks who don't offer insurance. And so their employees were going either into Catamount or into the individual market pre-ACA, or into the individual market with a premium tax credit post-ACA. You also had large businesses with very young employees who were paying a very small percentage of payroll. And you had employers like the state who would have seen a windfall from the payroll tax that the state was proposing. And so the range of winners and losers in the state and the employer community was really difficult to navigate and also to manage in terms of how you sort of transition from the current system to the new system without having a significant shock to your economy. In addition, in the design of the benefit structure as well as some of the eligibility, there were certain policy decisions that were extremely important to Governor Shumlin. But they were policy decisions. Some of them were expensive. And so that also impacted the price tag. So for example, the benefit structure mirrored the equivalent of the state employee or the teacher's plan, which is an incredibly rich plan in the scheme of Vermont benefit structures. That's not a bad thing, but it does mean that the financing has to raise more money. In addition, one policy choice that was very important to him was providing coverage for the employees of Vermont employers, even if that employee lived out of state. So we have along the Vermont-New Hampshire border, we got a lot of Vermont employers who employ people from New Hampshire. It just happens to turn out that the demographics of that is that those New Hampshire folks are expensive, and the payroll tax is what it is, regardless of whether those folks are covered. And so that was another policy choice, which he felt like was the right policy choice, but was an expensive choice. Sort of the third example that I'll give of that is eliminating the Medicaid provider tax, which is a very circular, kind of weird, regressive tax. So that revenue source, which currently funds Medicaid, had to be replaced with something else. So, so that's kind of where at that point, when the financing plan came out, the governor had decided that he did not think that the plan with the policy choices that were important to him was passable in the state legislature, and so he chose to own that and not go forward with it. Since that time, there are a number of things the state has been working on, and those have primarily been around cost containment, I would say. Vermont currently has 98%, last I checked. Mike, you might have checked more recently than I, but we're between like 96 and 98% insured. So our issue right now is really the underinsured, and Mike can speak to that much more eloquently than I can because his office speaks with a lot of folks. So I'll leave that for you, Mike. But I would say most of our efforts have been more around how do we reduce the overall cost of healthcare to make it more affordable through regulatory mechanisms or through payment reform mechanisms. So I talked a lot just now, so I'll pause and let Mike chime in.
Yeah. I think I'll go back a little bit. You know, Betty introduced me already. I was a member of the legislature. I was vice chair when we passed Act 48, and then I was chair for the subsequent 3 years. So it is burned into my head some of the debate that happened in those years, and so when people say, you know, Act 48 didn't work, it was never implemented. Betty, I can't help but think, hey, I was asked on the floor over and over and over again, what happens if we can't pass a financing plan? And the answer that I gave and what came to be was that you know, we had to pass, it was contingent on the ability to pass a financing plan. And so we all knew that we didn't, you know, that was a major, significant hurdle. But there was active conversation before we passed well, after we passed, when we passed Act 48, and then after in the subsequent years, I want to call it Act 116. Robin, you have any memory of that? The next couple of years where we fine-tuned a lot of things and set up the exchange and so on. It might not have worked the way we wanted, but it did follow one of the paths, as frustrating as that was. I guess I'll speak for just a minute about what we haven't done. Robin's right. My office speaks a lot about the tremendous growth in underinsurance. I think probably everyone here knows it or knows the arguments around it. But Vermont, for commercially insured people, our underinsured rate is, I think, 44%, according to the last household survey 3 years ago. Looking forward to the next one, and I'm afraid that number will grow. So, we continue, despite a whole lot of efforts by Robin and the Green Mountain Care Board to regulate this system, we continue to have a lot of Vermonters who are, we're just very much afraid, are unable to afford the care that their providers recommend. Another major area, maybe it's an overlapping area, where I feel like we haven't been able to focus on. Hey, the ACA didn't focus on Medicare. It focused on families, and it had a big impact nationally on Medicaid for children and adults, but it didn't touch Medicare for the age, blind, and disabled. And Vermont and our country has been largely asleep at the wheel in that area of health policy. And so, the eligibility levels for people on MABD Medicaid are, I'll say criminally low. If you're a two-person household outside of Chittenden County, MABD is around 74% of the federal poverty level. I mean, it's not even up to 100%. So that's just one of the areas that we continue to focus on as an area where we really need to move forward. You need to address. I know that wasn't your question of what did we do. I focused on what we haven't done.
And then, so I noticed Robin's been answering the questions in chat. Did you want to elaborate a little bit on them verbally, or did you feel like you covered?
Sure, happy to, if that is helpful. So I think, the question of how detailed to be in legislation is difficult to answer without knowing a specific state's culture or legislative capacity and staffing. So for example, in Vermont, we have very limited legislative staffing. We have just nonpartisan staff, which serve all the legislators. I used to be one of them. There literally is a 3-person healthcare team that covers everything from Medicaid in the budget to anything involving health or human services in either chamber. So most legislatures tend not to get into the weedy details, at least part-time citizen legislatures like Vermont. That may not be the case in California and New York, for example, where they're more professionalized. But it's really, in some ways, it could be a strategy question of what is the better strategy to pass legislation. In our particular case, Governor Shumlin ran for governor on creating a single payer system. So it was important to him to get a bill into place early as part of his, fulfilling his campaign promise. It took, and that was in 2011. We passed that in 2011. And it took literally 3 years. It probably would have been quicker without having to also stand up an exchange at the same time. But because that was a lot of work and it was the same people doing both tasks. My office, which at the time, which did the analysis around the single payer or universal coverage system, we were literally 3 people. So in Vermont, we tend to do things on the quick and the cheap, but that means it does take time. And so we did a series of successive reports to get deeper and deeper and deeper into the weeds. So we investigated all of the potential waivers necessary. We were in discussion with the federal government about those waivers at the time. And, if we had waited to file a bill until we had all of the details worked out, it would have been several years into, and Vermont only has 2-year terms. So that's the other key piece of information. We wouldn't have had time in 2 years to get to the level of detail and understand everything we needed to understand to make a proposal. So, other states have longer terms. They have more, legislators with actual staff who are dedicated to individual legislatures. And so it may be a different case in another legislature. Mike, do you have anything you wanted to add about that from the state legislator perspective?
Sure. I'll just say it's a difficult balancing act. And it's difficult when you have a governor who wants to do the same general thing that the legislative leaders want to do. The tension between the legislature and the administration is always there, even when you're in the same party, let alone when you're in a different party. And so that, legislatures often want to go to a more detail, pass successive bills that say we really meant it. But the legislatures, other than the power of the purse, the legislatures, they're not the administration as much as sometimes legislators want to be. So ultimately, I do know John Tracy. So ultimately, the legislature really gets to sort of point in a direction and ask the administration to pursue it.
So should I just go through questions in the chat? Would that make sense, Maria?
Yeah, I was going to ask, did you want me to read them out, or do you have it pulled up and just, I guess, go in time order? So whoever asks first.
I have it pulled up. So I'm happy to do that, or unless you prefer, whatever works for you.
Okay, that's perfect. For sake of the recording, if you don't mind at least summarizing the question, or if you want me to just read it out loud.
Yeah, I can do that. So the next question is about reimbursement rates, and should Medicare for All include a blended reimbursement rate for doctors and healthcare providers, average rates that are based on commercial Medicare and Medicaid rates? I think that is an important policy consideration that a state legislature or Congress, whichever, would need to consider. What we did in Vermont is we modeled several options. Our minimum option was an average rate based on Medicare, Medicaid, and commercial, and blending as suggested by Michael Pan, because we felt like that would be a more fair way to kind of transition folks. Because of course you can always shift your reimbursement rates over time, but there was concern about shocking the medical system in the transition and ensuring that there was enough money during the transition for folks. But different states can make different policy choices there. I think we modeled a pure blended plus 10% and maybe plus 25%. So part of what we were looking at is, could we make it attractive potentially by blending the rate, but then giving a little rate bump overall? Mike, do you have anything you want to add on that question?
No, I just want to do a little shout out to the challenge that that I feel like I'm fighting here in Vermont. I think in part, I know that Medicare for All is a rally cry for improving access to care. I'll just relate that in my challenge of trying to get people to recognize the challenges with Medicare, the deficiencies of Medicare, that I feel like I've been having to push back. Many of us have been saying Medicare for all for a while as if it's great. Medicare is not great. Medicare is deficient in many ways for many, many people. So I just can't help but want to say that out loud here. Improved Medicare for all or something. I just wanted to make that comment.
Great. So the next question is, a couple years ago, former Governor Shumlin told Healthy California Commission that Vermont had cut a deal with the feds and got all the waivers worked out. He said, my policy people, I'm assuming he means me, by policy people, policy person can tell you exactly how we did that, what waivers you need, and who you have to see to get them. Since there's no such thing as a single payer Medicare waiver, can I explain what waivers were obtained? Yes. So what we did not get to the point because of not passing the financing to file the paperwork for the waivers, but we were in conversation with the federal government about revisions to our Medicaid 1115 waiver, Section 1332 waiver from the Affordable Care Act. And then we were looking at the waivers available through Medicare, which are largely around the payment, not around eligibility or funds flow. So let me start with the two waivers and then talk about Medicare. So with Medicaid, Vermont has had a very flexible Medicaid waiver since 2005, called the Global Commitment for Health Waiver, which allows the state to kind of act from a federal funding perspective like a managed care plan, meaning that we can match at the higher level instead of the individual service level, and we can get Medicaid dollars to pay for things that are not traditional Medicaid services. So it gave us more flexibility in how and what types of things we could fund with Medicaid dollars. So our Medicaid waiver gave us a lot of flexibility in terms of benefit coverage and those sorts of things, so that we could have the Medicaid dollars come into the state and offer a plan that would use the Medicaid dollars towards our universal coverage program. We had made a decision that for folks who are Medicaid eligible, that the benefits would be more generous than the general benefit package that we were offering to the general population, because of course Medicaid has specific benefits to address some of the social determinants of health that are frequently an issue for folks living in poverty. And we didn't want to cut those benefits. So the Medicaid waiver was not that hard. I think where there's challenges with the Medicaid waivers is there are upper income limits that the federal government will approve. That's something that is required by federal statute. So you can't necessarily get more Medicaid dollars to do a universal coverage program than you would to do a different kind of Medicaid expansion. You still need to track eligibility because the feds are still going to want to know that you're only using Medicaid funds for appropriate Medicaid purposes. So there's a lot of back end stuff. And you can't really get rid of claims because you need to be able to show the federal government that people have access to certain types of services. So there are definitely limits with all of the waivers, and that impacts your design. In terms of the ACA waiver, when we were talking to the feds about the ACA waiver, nobody had done one yet. And they had not issued their rules. So we were really early. And that was a challenge because the feds were trying to figure out how they would handle those waivers at the same time that we were trying to figure out how much money we could get through that waiver. So we had a number of conversations with the Treasury Department as well as HHS in terms of like how to calculate the dollars coming through that waiver, and they were definitely more restrictive than we had been hoping. So, for example, with a 1332 waiver, it has to be what they term as budget neutral, which means they don't just look at the subsidy amount, but they also look at all the other components of the ACA, including some of the funding mechanisms for the ACA. And so they look at both ups and downs, which makes it a bit complicated. So the way I would think about that waiver is essentially like the Medicaid waiver, a funding source that allows you to support some parts of your folks who are in your universal coverage program. And there are the benefit package, there are guardrails for the ACA waivers about making sure that you're not reducing people's benefits or making them pay more. So you have to, that kind of ends up influencing your benefit design in your universal coverage program, because you need to make sure you're not falling below that floor. Not that you would necessarily want to anyway, but it becomes another analytical test. In terms of Medicare, Chris is right. There is no Medicare waiver that allows you to just get Medicare money into the state. The way the Medicare waivers work, they're really around payment and delivery system. So it can change, it can add benefits, it can't subtract benefits, it can reduce cost sharing, it can't add cost sharing, but you have to do that through paying providers some way other than fee for service. So because of that, where we had kind of gotten to in our program is that we would have our universal coverage program, sorry about the dog, wrap around Medicare. So we would have folks enroll in Medicare, and instead of buying supplemental insurance, our program would wrap around and be the secondary insurer, so that the benefits would look the same. The financing would obviously, and the claims and all that, the administrative stuff would not be the same. One of the areas that we explored was whether or not we could become the payer for Medicare. So Medicare bids out the actual administration of claims. So there's not, kind of a federal entity that pays Medicare claims. It's contracted out to different insurance companies around the country. And so we looked at whether or not we as a state could bid to be that insurance company for Medicare, thinking that that would, help us potentially streamline a little bit. They have regionalized that. So Vermont really wasn't ready to tackle being the regional Medicare administrator. So that ended up being a bit of a dead end for us. It's possible that in another state, that might be more feasible. I don't know. So that's kind of where we got with the waivers and Medicare. Mike, anything you want to add?
No, other than just to recognize, Governor Shumlin was a both feet in, he really believed it. And
I think he still really does believe it.
And he still really does believe it. So the quote, Chris, that you put on, that you wrote up there, he was really saying, we're gung ho, we're going.
Yeah.
Even if it wasn't quite that easy.
Yes. This was a common refrain in my life working for Governor Shumlin. He is at the vision level. He's not at the detail level. So Diane asks.
I'll do it, Robin. The next question is about many states privatize the administration of Medicaid. And evidently Minnesota is one of them. Where they contract with a Blue Cross or somebody to administer the Medicaid program. And I know Vermont is not one of those states. Medicaid in Vermont is run by a state agency, and and my office on behalf of Vermonters spends a tremendous amount of time advocating with our Medicaid agency. And as much as we have frustrations in that, I know, do not have anything like the kinds of frustrations that people have negotiating with private insurance companies who are managing Medicaid for their states. So thankfully, we don't have that problem.
That's true. it looks like there's a number of comments. And the next question I see is from Sharon about ERISA. Do you want to comment on any of the other comments, Mike, before we jump to that?
I haven't been scanning them. I'll look at them. Go ahead.
All right, I'll talk. So hold on. Hank had a comment around having a variable tax percentage to help with the shock of small business. There's a discussion about Medicare Advantage. And then Sharon says, could we comment more about ERISA and why that's a barrier? Sure. So ERISA preempts state laws which would impact employer health plans if the employer is self-funding. So it does not hamper a state regulating insurance companies, but for example, a state could not say to a private employer, you can't offer insurance to your employees. A state could also not say to a private employer, you have to offer our plan to your employees. So that's where the ERISA challenge comes in. If you want to have a uniform benefit design across everyone, I think what we were looking at in terms of ERISA is that it's clear that states have tax authority. So where we landed with this is we were doing a payroll tax. Every employer would pay that payroll tax. There would not be an exception if the employer chose to self-fund a benefit. We wouldn't prohibit that. They were welcome to do that and pay the payroll tax if they liked. But of course, I think for many employers, if they're paying a payroll tax, they may choose not to then offer their own plan because they would end up paying essentially twice. So that is allowable, I think, under ERISA, although I'm pretty sure you would still get sued because ERISA does not have a lot of settled law in this area. But I think, that's kind of a controversial policy. There are a lot of employers who are self-insured or who might be national companies who weren't really keen on that type of tax policy, because they want to be able to offer a uniform insurance product to all of their employees, regardless of state.
And then our next question we have on healthcare providers such as surgeons, specialists, procedural providers are mixed about improved Medicare for all because most of them see commercial patients and others see a mix of Medicare, Medicaid, and commercial patients. So what is the effect on providers' income?
Yeah, so I think that will depend on the provider, right? And what their payer mix is. I think that's really what Michael is getting at. So if you are a provider, so I'll just use a couple of Vermont hospital examples because those are what I know best. So we have some Vermont hospitals where their payer mix is, if you look at combined Medicare and Medicaid revenue, it's like 60% of the hospital's overall revenue. Commercial might be 40%. We have other hospitals where commercial might be 60% and Medicaid and Medicare might be closer to combined 40%. So if you shifted the payment to Medicare payment rates, hospitals with a high commercial payer mix would see a decrease in revenue, and hospitals with a low commercial would be impacted less. But I think to your earlier point, if you shoot for a combined sort of blended payment rate, you can kind of mitigate against that dynamic.
And Michael, did you have anything to add on that one?
No, other than I think it opens up the door to a very, very, very tough challenge in this whole conversation, and that's how much is the right amount to pay providers. I can tell you that major hospital systems in Vermont, well, I'll just say my perspective as the healthcare advocate is that they will justify sucking every dime off the table that they can find. And it's very tough to manage that. So, what is the right amount to pay them? I think is not a simple answer. And what does it actually cost to provide care is something that I don't think we really know.
And then, so it looks like we don't have any other questions in chat right now. So I'm going to switch to another one. Oh, Dr. Keller, do you have one?
Actually, I do. I don't remember, Mike, what meeting we were at, but somewhere along the way you said that some other states do a better job of helping out people on Medicare than Vermont does. And I'd like you to talk about that a little bit, if you could, please.
Well, sure. So Barbara in the next question mentions Quimby. I try not to say the term Quimby, qualified Medicare beneficiary, because it's wonk speak that most people glaze over for. But Quimby is a Medicaid program that wraps around Medicare, and it many, a handful of states have gone above the federal minimum. Quimby acts very much like Medicaid. It covers people's care, and as many people know, Medicare generally covers 80% of hospital and outpatient costs. And so in Vermont, Quimby caps out at 100% federal poverty level. What is that? 14,500, I'm gonna guess, range for a family of one. $14,500 a year, fixed income. If you earn more than that, you don't get that coverage for the 20% cost sharing. And so, hey, it's pretty easy to run up a $5,000 bill when you go to the doc, right? Doesn't even have to be a major deal. A person who's in the $14,000 a year income range, who gets a $1,000 bill, can pay it. They're not gonna pay it. And yes, many states have done a better job. Interestingly, states in New England, New York, Connecticut, DC, and a handful of other ones, I'm not remembering them all, have done a better job. Massachusetts, of raising Quimby levels, at least equivalent, I would argue, at least equivalent to Medicaid for children and adults, so that when you turn 65, happy birthday, you don't lose access to care.
And then Lou had, I think, a follow-up question to the previous point. He's asking about savings and insurance administration.
Yeah, savings and insurance administration is a place where it's easy to overpromise. And that was actually a challenge that we had in our initial report that was done by Dr. Shao to the legislature in I think it was in January 2011. Like, we were never able to replicate the level of savings promised by that report and future analysis. And so that became a political challenge. I think the challenge with savings administration, insurance administration, is like which part of the administration, right? So you could have some streamlining of enrollment and eligibility, for example, because you wouldn't have multiple insurers doing that process. Some of that, quite frankly, has happened in some states with the insurance exchanges already. I think the trickier part is where there's a promise of a lot of savings is in the claims processing side. But at least as a state trying to pursue federal waivers, the waivers don't extend to not paying, not continuing to collect data and information about what services are provided. And so if you look at, for example, the Medicare payment waivers that have been issued, providers may be receiving a fixed global budget, for example, in Maryland and Pennsylvania, but they are still producing what are called zero paid claims. So the claim is not the place that they're getting, the basis for which they're getting payment, but they're still submitting documentation about what services were provided. And that I don't really see going away in Medicaid or Medicare, because the federal government has to be accountable to Congress in terms of where those federal dollars are going. And so they need the statistics about what is actually happening. And so that's an area where I think we ran into some trouble in terms of calculation of administrative savings. If providers are still producing claims and those claims are still being processed, I think you could argue there theoretically could be some savings, because you wouldn't necessarily have prior authorizations, for example, which is of course a big source of administration for providers. But the other challenge we ran into is when we looked at administration in provider offices, we had to face the question of, okay, so most of our provider offices are fairly small. They might have one or two administrators, scheduling patients and taking care of claims. Are they going to lay those people off? That's where you get the savings, is laying those people off. Or are they going to repurpose those folks and have them do different things in the office, thus not really achieving any savings? So I think administrative savings is tricky, because what you have to really think about is which people in the insurance company or the provider's office are going to get laid off, because that's where you get the savings. And is that actually going to happen in reality, or are those people going to get repurposed into other roles so that the cost remains the same, even though the task might be different?
So Robin, but they wouldn't have to be chasing the dollar. So
they wouldn't have to be, right. But there may or may not be savings. There may be different administration, right, but there may or may not be savings.
Right. And I just want to add on, as Robin's talking about the global budget, or the capitated or value-based payments, that the way that we are experimenting with paying providers for caring for people or communities. As the advocate's office, I also can't give up zero, shadow claims. Isn't that what we call it, shadow claims?
Yes.
Because of the fear that providers will save money by not providing enough care. So it is how we have measured whether providers are actually providing care to people.
And then I'm going to step in real quick because we're at the 9 o'clock mark. I know, Robin, you said you need to go by 9:15. Mike, I think you're on the same schedule, right? So if you guys have any other questions, to drop them in chat, we'll answer as much as we can until they both need to go. But are you guys okay with afterwards, maybe if we collect any other questions that weren't asked and then send them off to you both?
You can. I can't make any promises depending on the question as to how extensively I can answer it, just because I do have limited time. And so yeah, I'm happy to give it a shot.
Yeah, we'll do our best.
Okay, we appreciate that. So moving on to the next question, then Mary Alice has a question about the CEO salaries. What happens to those?
Yeah,
about them?
Yeah. Could be some administrative savings there. But in Vermont, it's not that much money, just to be frank. It could be a lot more money in other states, right? We basically have one insurer in the state, and you wouldn't sort of eliminate hospitals, right? So the hospital CEO salaries would presumably not necessarily change, but we would cut a C-suite from one insurance company in Vermont, which just won't add up to that much money.
Unless we hired that insurance company to administer it.
Yes, which actually was part of the Shumlin plan at one point, was to potentially hire that insurance company to save the jobs. Right. So good point, Mike.
And then our next one is a 3-part question. Do you guys want me to do one by one or all together?
So, Joe, do you mean reach, or is Joe talking about a head?
Talking about the REACH program in the federal government under CMS that's privatizing traditional Medicare under the Innovations program that was started under the Trump administration and is being continued quietly under the Biden administration, where incentives like in Medicare Advantage are being given to, okay, do you know about this?
Yeah, there's the REACH ACO program. My understanding is that program is closed and will be discontinued at the end of the current participation agreements.
Wow, that's really good news.
That at least that's what CMMI has said to us. That it'll take a little while for that, I think, to sunset, because they made, multi-year agreements with certain ACO programs. But basically what that program was doing was doing direct provider payments to ACOs, using, to Joe's point, a similar algorithm to what is used in the Medicare Advantage program to the Medicare Advantage insurers.
That's good to hear, Robin. Thank you.
Yep.
Joe, I don't know what the medical society's position is on healthcare for all or Medicare Advantage, but I know of your concern about Medicare Advantage, though I try not to call it Advantage because it is not an advantage.
Yeah.
Medicare Part C, for everyone who's keeping track, is the same as what is called Medicare Advantage. Just to recognize, we have, Vermont has, I think, been blessed because we have been behind the growth curve in the uptick of people moving to privatized Medicare or Part C. But that is changing. Vermonters,
I hope so. What the governor tried to pull last winter on state employee retirees was a real wake-up call. I'm trying to force us, I'm a retired state employee, I'm trying to force us to take Medicare Advantage. And then of all vendors, Cigna, to make Cigna the vendor that just paid $172 million in fines to the Department of Justice for Medicaid payment fraud. Honestly, I was in the legislature last winter getting help from the legislature to stop this, which they did. But sitting next to Beth Fastigi and Kristen Klauser in the Government Operations Committee and listening to them tell how great this policy by Cigna was going to be for us, and they had a 5-star rating, while I had just read in the New York Times about the lawsuit. It's just made my head explode. So the more education we do on Medicare Advantage and what a ripoff it is, the better off everybody will be.
It is, for people who don't know, my office runs a helpline for Vermonters who are having any kind of access to care problem. And it is if you don't have claims, if you don't have expenses, the only thing you have to measure your health insurance, the only factor is how much you pay in premiums, right? So lots of people who don't have a lot of healthcare costs love their insurance company if the premium's low, right? No other concern. And then they get sick and they need some care. And then they start to interact with their insurance company to find out whether it's going to meet their needs. And it is a regular phone call, to my office from Vermonters who have bought an Advantage. I did it, a Part C plan. And they go and they find out that it's not meeting their needs.
Well, through things like pre-authorizations and then denials and then delays and then appeals. And by the time you go through all this, you're not getting the treatment you need.
Right.
And then we had another question. Are there other states which have maintained direct management of Medicaid besides Vermont and Connecticut?
I think I just heard of a third state that was considering moving, but I can't remember the state. But so I'm not positive. There might be a third, but I think Vermont and Connecticut are the ones that I know for sure.
Okay. And then any comments to share about what this new AHEAD program is?
Sure. So CMMI, the Innovation Center, recently announced a couple weeks ago that they're pursuing a new payment reform model that they've called AHEAD. They, as folks may or may not know, the Innovation Center currently has state agreements with 3 individual states, Maryland, Pennsylvania, and Vermont. Each of those are one-off agreements between the federal government and the individual state. They want to move away from these types of individual agreements. So they've tried in the AHEAD model to create a model for those 3 states plus states that they consider to be further along in payment reform. So New York might be an example there potentially, that they're hoping would be attractive. The model includes a hospital global payment from Medicare, and a primary care per member per month. So those are the 2 payment models. Overlaid on that, the state would have to agree to a total cost of care trend, and also a minimum primary care spend, meaning they want to ensure that there's more investment and growing investment in primary care. There's been some confusion about the term minimum. I think some people interpret that to mean less. CMMI's intent, I believe, is that it's a floor that they'd like to see exceeded. There would be quality measurement. There's a big health equity focus. Each state and each hospital participating would have to create a health equity plan. Payments for hospitals in the global payment would have some health equity component. I think those are kind of the broad strokes. So it's really hoping to create a constraint on the hospital side and an increased investment on the primary care side. We'll have more information in December because that's when we're thinking they are. I mean, don't hold me to the date because things move, but that's when we're hoping to see their notice of funding opportunity, which will have more detail than their announcement.
And then I believe this might be the last question that we have time for, but Mike wanted a comment on the statement that not adding more ACO REACH programs does not prevent existing ACO REACH programs from amassing patients. So we wanted your thoughts on that.
Yeah, in the short term, right? So there are certain entities that have been accepted into the ACO REACH program for a period of time. During that period of time, they could actually, increase their attribution potentially. But after a certain, I don't remember the date, but after a certain period of time, those would be sunset. So those patients would move out of the ACO REACH program into potentially back to fee for service or a different payment model. That's my understanding. I'm not an expert on ACO REACH, but that's my understanding from the federal government.
And then we actually have one more. Let us say that hospitals do support Medicare for all. However, they are skeptical about implementing global budgets. What is your plan to maintain fee for service for hospital services? And then in parentheses for profits.
I can only really speak to Vermont hospitals, and I would say that in Vermont we had, I think, a mix in terms of whether our hospitals supported going to a universal coverage program, and I would say that we have a mix in terms of those who would be interested in implementing a global budget. So we have had a couple of hospitals that actually have been advocating to get a global budget for over 10 years. And we are considering as a state whether or not to apply for the AHEAD model. And so we've been running a hospital global budget technical advisory group. That is a mixed stakeholder group, meaning hospitals, insurers. Mike is on it. We have the NEA, a few other folks, to try and see if it makes sense for the state to propose its own state-based methodology on hospital global budget. So, and our legislature has directed us to explore different payment methodologies and to move away from fee-for-service. And I should also note that we don't have for-profit hospitals in Vermont. So I just noticed the question says for-profit. We don't have those in Vermont, so we don't really have a plan related to for-profit hospitals since we don't have any. But we are exploring whether or not global, like to call it global payments, because we have a hospital budget methodology in Vermont where we regulate hospital revenue and commercial rates. So for us, it would be having the payment flow in a different way underneath our regulatory system. So I'm not sure I actually answered your question, but that's all I really could contribute.
Then the last question we'll take, since we have just a couple minutes, is how can a hospital and an insurance company get together to run a Medicare Advantage plan?
Evidently they can.
Yeah, I mean, it's allowed under the federal Medicare Advantage.
Yeah, this
rules,
is
I
fully
think.
federal law. And we do, you know, I assume this is about MVP and UVM Healthcare having some kind of a partnership, and it is allowable, and something that we've had a number of questions about. I'm not sure I've gotten clear answers yet.
Okay, and then I don't know if either of you want to, oh, Dr. Keller, you have a question or a comment?
Yeah, I just building on that question about that referred to hospitals that were for profit. Because we're in Vermont and we have no for-profit hospitals, we have a totally different situation from all the states that do have them. So for the benefit of the other states, can you just talk a little bit about, very briefly, because we're at the end of your time here, how is that, how do you do that? Like, is it a possibility that is no longer possible due to federal law, or can states still do that? And how would somebody advocate to do that in their state?
Yeah, there's nothing in Vermont law that prohibits a for-profit hospital. So I don't know how we ended up there, to be honest. So it's not a legal constraint. It's just, I think, the way our hospital system evolved. We have had this hospital, budget process in place since the 80s, I think, 1980s. And so that may have had something to do with it. But I really don't know. I'm not an expert in corporate law, and that's really a corporate law question in terms of the state authority to, disallow for-profit corporate entities for certain types of services. So I don't really know. I think so I think that would be you need a corporate lawyer to answer that question.
Okay, I totally thought we had a law against it. I'm sorry. So thank you.
No, we don't. No, we don't have, I think our culture as a state probably, because the other thing we don't have, quite frankly, is venture capital. Like, that's a huge trend nationally. We really haven't seen venture capital coming into our state in the healthcare sector at this point. Maybe it's because we still have a fairly strict certificate of need law. So if you want to do a new venture, you have to, jump through the certificate of need hoop, which is not a barrier in many other states. But I don't know. That's speculation.
Thank you.
Yep.
Okay, yeah, so that is the end of our time. If anyone has any questions, you can feel free to either email me or Dr. Keller. I can drop my email in chat, and we can forward them along. I really appreciate you both for taking the time to come speak to us and answer all of the questions that we had. I felt like I didn't know that ACO reached that they were ending it. So at least we got some good news from today. I'll stay on for everyone else in the Zoom. I'll stay on if anyone has any questions about Cyprus specifically. But besides that, Robin and Mike, you are both good to go. I really appreciate you guys being here.
Well, thanks for having us.
Yeah,
you so
thanks
much.
everyone.
Thank you. And I think there is the opportunity for a little bit of interesting discussion around Cyprus if people are interested in staying on for a few more minutes. So a couple of things that strike me about Cyprus, Maria, is that the capitation that the primary care doctors have, which is only GPs, this is not the pediatricians and all like we have in the United States. The capitation is more like that payment for having a home, what do they call it, a medical home, rather than but it doesn't actually require that that what the doctor gets for a payment for that patient does not, you don't take the x-rays and the specialist visits and the hospital stays out of that. Whereas in capitation for your typical managed care program, you get a lump sum for your patient and you're responsible for the care that comes after that, which is very risky for an individual provider. You don't know how sick a patient might be. So it's very, very risky. So that's an interesting feature of Cyprus. And
that's one of the things we've also changed that a lot. So how we pay doctors now is very different from how we originally paid them when they started with ESC. So originally it was all fee for service. And then they were like, well, realizing sort of you can't blanket statement everything. And also like the quality was sort of going down because then the GPs are just doing all these services that they don't really need to do, or they're like marking them up. So basically they were saying, okay, well, we'll give you, I think it's 70% your capitation, or like how many are registered under you, and then 30% fee for service. But also if you have too many referrals, if you have too many like consults, like too many of these things, you lose 10% of that salary also. So they're trying very much to get that sweet spot so it avoids all those like extra consults, extra referrals, while also still, okay, you do need to refer sometimes to a specialist and you do need that benefit for referring. So it's interesting where they're like messing around with the sweet spot still.
Yeah. I have a question about Cyprus healthcare system. After it's implemented, did a lot of the local residents experience increase in healthcare wait times after the implementation of?
So no, it seemed at first, it's been a yes and a no. So it's a yes for their preferred doctors, but no for seeing any doctor. So for example, if you want to go see a specialist and you get a referral, with that referral, you can see either 2 doctors or 1 doctor with 2 visits. And so basically what patients will do is they have their preferred doctor. Those doctors are taking on more patients because now everyone wants referrals, right? So their wait time is a little bit longer, but those doctors of maybe lower quality or less reputable are more open and they're all under the system, and you only need to pay €6 to see them versus 120 that you were paying before. So patients will go and do, okay, this doctor's available within a week, I'll go see them, and then in 6 weeks I can see my doctor that I had wanted to when they're available. So it does sort of like cause some issues in that, where like then you're questioning, okay, standard of care, because you're seeing those quote unquote worst doctors right away. But it does mean that there are always like some sort of doctor available that's in the system.
Yes,
So it's a yes and a no.
yes and a no. Yeah, the reason I asked that question, because in Taiwan, in Taiwan's single payer system, or I should say the hybrid, more like it's Medicare for all, but there's some out-of-pocket costs that patients have to pay. So when patients see a specialist, they actually don't need a referral to see a specialist or surgeons. It's just a direct entry. So there's no gatekeeping. So when patients schedule their appointments, they can go online. They can go on the portal system to find availability, and it's very quick. And Taiwan uses an electronic payment system. When patients see a doctor, after patients are done seeing their providers, they go to a kiosk screen to make payments, and it's very retrievable. It's very easy to make payments, as opposed to like waiting like several weeks in the mail to get a bill. So Taiwan learned the good and bad. I mean, learned the pros and cons of single payer systems of Canada, Denmark, America, and decided that wait times are going to cause, issues for local residents. So the only way to relieve wait times in Taiwan is to issue out-of-pocket costs. So that way it relieves pressure from the government to fully fund, specialty care and surgical services.
Right. Okay. Is there any sort of like, if you get referral, it is covered, or no, it's just fully, we always have to pay for it?
Oh yeah, so I think it's, from my understanding, is that when you see a specialist, like I'm not sure how many visits they will cover for you, but I think like if you go in there like the first, second time, I don't think you have to pay out of pocket. But if you use like the specialty social service more than frequently, yes, there's like a copay that patients have to pay out of pocket, but the copays is very minimal compared to American standards. Because I know in America the copays are like at least $100 and up. And so
Okay.
yeah, and they don't believe in gatekeeping, so they use electronic, system to combat wait times. Whereas Canada does not use that. But from what I read about Canada's healthcare system, some Canadian doctors are using it's a new system they just implemented about a couple of years ago. It's called the electronic referral system to alleviate wait times, and it has not reduced or alleviated Canada's wait times, because not a majority of physicians in different provinces have successfully implemented, or they didn't have the training to do it. So it's really like a mixed bag, and wait times in Canada going up every year, and nothing's being mitigated.
Yeah. Luckily we haven't had that big of an issue. We have seen like an influx of doctors taking patients, and then I think also they have GPs can technically take up to, let me double check on the number, but I think it's 2,500 patients a year, and then on an average like patient goes to a GP 4 times a year is what they had on average. So that would equate to like out of 200 working days, like 50 patients a day, which is still not realistic for us. But that's one of the critiques of our system. But the wait times itself, again, is mainly, it just depends on the doctor. But you can always re-register. I guess for the specialties, it's not as bad. With the primary care, you do need to re-register if you're seeing a different primary care. So that's where it could maybe cause some issues.
Right. And when you say like up to 2,500 patients per year, is that like a quota or cap? And with a quota and cap, does it come with like the needs of urgency and non-urgency?
So that's a cap. So it's like GPs are allowed to have 2.5 thousand patients a year. But it's not like, oh, you have to have at least so many. Obviously, depending on like what salary you want, it depends on, because you have the capitation. But that's where sort of patients are also allowed to switch GPs at any time. So say that a GP does take on too many patients, and then their patients end up getting frustrated because they can't get an appointment and they need an appointment and they're always like 2 months booked out or something like that. If they re-register to another GP, then that GP that they were originally registered under doesn't get paid for that capitation anymore. So it goes by month. It's 100 euros per year generally for a person, but they pay it on a monthly basis depending on how many are registered that month, if that makes sense.